As I said, I'm speaking here in my capacity as a volunteer with the American Heart and American Stroke Association. As you kindly presented my credentials, I am a stroke neurologist. I am the medical director of a stroke unit, and I'm also a rehabilitation neurologist and work closely with my physical therapy, occupational therapy, and speech therapy colleagues to provide new lives for our stroke patients. I'd like to start with reading this statement, but then if you give me a moment or two, I'd like to add some personal observations. So, on behalf of the American Heart and American Stroke Associations, I am pleased to be here on behalf of the estimated 6.4 million Americans who've had a stroke, about 70 of which are Medicare beneficiaries. Many of these older Americans are fighting just to recover from their stroke and aren't able to come to Washington today to advocate for an exception to these therapy caps. So on behalf of the AHA, ASA, and stroke patients, I want to thank the Senate for bipartisan action last evening to temporarily protect Medicare beneficiaries from the rationing of therapy services. And I applaud the House for passing this short-term legislation last week. But the job is not yet done until Medicare beneficiaries are protected from these therapy caps for the longer term or even permanently. Stroke is a leading cause of disability in this country, with about as many as 30% of our stroke survivors being permanently disabled. The good news is that we have made tremendous progress in the last 20 years and as a nation in helping stroke patients to make a significant recovery. Between 50 and 70% of stroke survivors will regain functional independence, but in order to have the best opportunity to do so, they need access to the recommended acute therapies and the appropriate rehabilitation therapies, what we say is PT, OT, speech, and so much more. Effective post-rehabilitation can prevent future health complications, improve recovery, and allow patients to live independently, all of which may ultimately help save Medicare money. In studies that have shown that if you, as a stroke patient, go through a stroke program with the rehabilitation part being a key element, you're more likely to be alive at 1, 5, and 10 years and living at home at 1, 5, and 10 years. And isn't that what we're really trying to accomplish here? Approximately 440,000 Medicare beneficiaries of age 65 or older are hospitalized for stroke each year. According to the 2004 Medicare claims data reviewed on behalf of AHA, ASA, about 1/4 of Medicare beneficiaries hospitalized for a stroke subsequently receive rehabilitation services through a nursing home, or more importantly, an outpatient setting or an inpatient rehabilitation facility which transitions them to outpatient and then on to home. This makes stroke one of the top diagnoses for which Medicare beneficiaries need physical therapy, speech therapy, and occupational therapy. Again, at Johns Hopkins, every day I meet with PT, OT, speech, social work, and nursing on every single stroke patient in our stroke unit. We are such a heavy user of rehabilitation services. We have our own dedicated therapists and physical medicine physicians assigned to our unit, and Hopkins is a stingy place. They're assigned to me and my unit because we have to work as a team every day to help these folks. We estimate, based upon claims data, that as many as 5 to 15% of Medicare beneficiaries with stroke receive therapy that would exceed these caps. While this may seem like a small percentage, it still represents thousands of Medicare beneficiaries who are potentially impacted by these arbitrary limits. And, unfortunately, these caps are rationing care to the most vulnerable stroke patients who need the therapy the most. The negative impact of the caps on stroke patients can take several different forms. There will be stroke patients who are able to continue to receive rehab through a hospital outpatient department, although perhaps with greater difficulty for themselves and their families. We know that there are other patients who will simply just give up, not just until the exceptions process is back in place, but permanently. And yet other stroke patients will have their therapy treatment plan altered to account for these caps, resulting in less intensive and suboptimal care. To give you a more specific example, it is not uncommon for a stroke patient to need all three: physical therapy for walking and mobility, occupational therapy for cognitive, but what we call functional independence, the activities of daily living that you and I take for granted: feeding, dressing, bathing, going to the bathroom. Speech therapy for not just for swallowing, but for language and communication. This makes this combined cap for PT and speech particularly burdensome for stroke patients. The stroke patient needing both physical therapy and speech therapy 3 times a week could easily reach their combined cap within 3 weeks. It's a 1-year journey after your stroke. A lot of the recovery occurs in the first 90 days. 3 weeks, we're just getting started. This is like interrupting antibiotics halfway through a course of treatment. The current exceptions process has been an effective way of ensuring that Medicare stroke patients aren't denied needed care. Now that Congress has provided some immediate relief to Medicare beneficiaries being affected by the caps, it's critical to extend the exceptions process for the longer term to allow these individuals to have the peace of mind that therapy services will be there when they need them. Congress, Medicare beneficiaries are counting on you to take action again before March 31st to avert similar problems a few weeks from now. But now my personal remarks. So I've been at this for over 20 years. This is the only patient population I take care of. And it has been my observation that within the United States and the general public, people don't understand stroke, and they're not really aware of what stroke is and how we recover from it. What perplexes me even more is how the healthcare community knows very, very little about stroke, other than some of the gentlemen here. Physicians, nurses, well-intended administrators, and other people who think they understand how we take care of stroke have misperceptions. It's not about death and disability only. It's not about either die or permanently disabled in a nursing home. 30 to 40% of my patients who survive stroke have little or no deficits at a year. You'd be surprised at the number of stroke survivors who are walking around you, still driving. And that next 30% or so are home and disabled, but they have quality of life. They may require their spouse to help them get dressed in the morning, but as I say, on Christmas morning, they see their kids, grandchildren enjoy the presents they got for them. There's quality of life for these people. That all happens because of rehabilitation. We concentrate so much on prevention and the acute treatment and the ambulances and emergency rooms with our sort of all new toys, this drug called TPA, for example. But it's rehabilitation that really puts these people's lives back together. And it is intensely frustrating for me to see it cut, because what we have now is barely adequate compared to the 70s and 80s, where you might be in a rehab facility for 90 days. You're going to be in inpatient rehab for 10 to 14 days right now, and you're going to be transitioned to home very quickly, and it's going to be outpatient. If I ask my stroke patients the number one thing they're frustrated about, they come tell me, why does the rehab services cut off so quick as they do? And my colleagues who treat pneumonia get antibiotics. That is the treatment for the disease that they fight. The oncologists have chemotherapy. If you have appendicitis, an anesthesiologist has drugs to put you to sleep, and a surgeon a scalpel, and he'll suture you right up. Our treatment is rehabilitation. And we're talking about taking away that treatment from me to provide for my patients. And there isn't going to be a cost savings. Because if the rehabilitation services are cut back, we're going to have more failed discharges. They'll end up U.S. nursing homes, Medicare, Medicaid, Social Security. There's no cost savings here. There's just more despair and disability. My dad's a stroke survivor, went through a rehab program. He's 82, he's still running his business and driving my family crazy. We need more of my dads in this world, who is a steadfast, conservative gentleman who hates paying taxes, but he's happy that the government is not taking care of him in a nursing home. Thank you very much.